مساء الخير على حضراتكم جميعا. طبعا ليا الشرف ان انا كعادة كل سنة ان احنا نشارك في المؤتمر العظيم ده. احنا التوك بتاعتنا سريعا عشان التايم. هدفنا نشوف في الاسوفاجيال مانومتري والبي اتش امبيدنس انفستيجيشن ايه اهميتهم، هل هم مفيدين او لا.
جينا ممكن نقرب المايك بس.
اوكي. Okay. I would like to welcome all. It's my honor to share my topic in this great conference, as usually every year. For the sake of the time, let's start. Our talk is about understanding parameters of esophageal manometry, pH metry, and impedance in cases of GERD. I will start by the American guidelines. American guidelines is telling us about patient with reflux. We will start PPI trial if completely relief. So we will discontinue PPI, and if symptoms recurs, we will investigate. Or from the start, if no complete relief, first we will proceed for upper GI of PPI 2 to 4 weeks, and it will differentiate between if there is grade B, C, D reflux or Barrett's more than 3 centimeters, so we confirm a diagnosis of GERD. But if it's normal or grade A, so we want to do reflux monitoring for diagnosis. If it's abnormal, so GERD is confirmed. If it is normal, consider other causes as we will discuss later on. So, according to these guidelines, I will start by pH monitoring. It's a procedure to monitor pH values in the lower esophagus to record acidic refluxes through transnasal catheter, which track the whole esophagus and will stop 5 centimeters above the cardia. This procedure is for 24 hours through connected this catheter by a data logger small device to record this patient through 24 hours exposed to how percentage of acidic refluxes. We have 2 types of this investigation: pH only catheters, which will record pH refluxes less than 4. So only highly acidic refluxes will be recorded in this catheter. We have another type of catheters, which we will discuss later on, the impedance catheter. It will record a different type of refluxes later on. So, the 24-hour pH monitoring for 24 hours will measure the number of acidic refluxes, as we said. So, in rest, pH is about 6 to 7, and during acidic refluxes, it will drop to 2, 3, and it will record these refluxes. So, this is a picture of our patient transnasal catheter, and this catheter is connected outside with this small device. If you can notice, this device containing many buttons, which the patient will use during the 24 hours. There is one button he will press if he is eating, and another button will press if he is in a supine position, and another button, the big one, which has the heart shape, if any symptoms occurred. This point about symptom correlation with refluxes attacks he will experience through the day is very important, as I will tell you later on. Okay, so this patient, we inserted the catheter and it stopped 5 centimeters above the cord. What it will record, as we said, any refluxes acidic pH less than 4, it will record it as an attack of reflux. So, through 24 hours, it will record number of refluxes, percentage of reflux time, percentage over the day, number of longer refluxes more than 5 minutes, and also it will provide us by a score, Demister score, which is very important in acidic refluxes. It's a logarithmic calculation using all the previous points. Normally, this score is less than 14.72. If it's higher, so it's a positive correlation. So, what we got benefit of at end of the study, first, quantitative data about how many attacks per day the patient has experienced. Also, it will make relation between the symptoms and the reflux events the patient experienced through the day. Okay. What about the another type of catheters? Impedance catheter. Impedance per se means resistance created by an alternating current. Any current is moving, air, liquid, any current has a certain resistance, so impedance will record. So impedance catheter will tell us about which type of refluxes, either it's liquid or gases or mixed. And also it will record any pH reflux the patient experienced. Not only the acidic, it will record also weakly acidic and will record alkaline refluxes. So all types of refluxes will be recorded. Okay, how it will notice a reflux? As we said, the direction of the current will diagnose the reflux. Look, this is a reflux of the gastric content downward, going upward in the esophagus. Then this reflux will be cleared by the peristaltic contraction. So it forms a pyramid-like picture. Liquid moves up and then cleared by peristaltic contraction. This pyramid shape is a reflux attack. In the past, pH less than 4 only was the reflux. Now we can consider less than 4 is a highly acidic refluxes. 4 to 7 pH is weakly acidic refluxes. More than 7 weakly alkaline refluxes. So combining pH and impedance monitoring will get the benefit to diagnose any type of refluxes, as we said. Also, correlation of symptom with the attack of reflux occurred. If the patient has a symptom in average 2 minutes of true reflux, so it's a positive correlation. But if the patient has a symptom in a period no reflux here, so it is a negative correlation between the symptom and the reflux, and it will help us to diagnose whether it's a functional or true pathologic reflux. This one is very important, symptom association probability. It's a score. It's a score calculated through the day, give hints about if more than 95% positive correlation between symptoms and occurrence of reflux, so it's a positive correlation. So, when to ask for pH impedance monitoring? First, patient has incomplete response to PPI. We can call it a refractory GERD. You want to know either he is a true GERD or he has something like functional heartburn. Okay, so in this case, for diagnosis, we should do the pH monitoring after cessation of acid suppressive medication for at least 3 to 5 days to emit any effect of drugs. Okay, give me a chance to explain when to do patient on PPI. If he is not responding to treatment and I want to know on PPI, is there a control for refluxes and the patient is still complaining, so it is functional, or PPI is not controlling his attacks. Okay, extraesophageal symptoms, this is another indication. If patient with extraesophageal symptom like hoarseness, aspiration, dental erosion, chronic cough, not typical reflux symptoms, we will ask for pH impedance. Okay, as I said, positive correlation or negative correlation, I will explain here. Patient with positive refluxes attacks through 24 hours is sure a reflux patient. Okay, so if patient is not pathologic reflux attacks, he has physiological attacks of reflux, as most of us have attacks per day, but it is not pathologic. So if it is physiological results by pH impedance, I will calculate SAP, symptom association probability. If it's positive, so the patient have symptoms nearby the physiological refluxes through the day, so he is a reflux hypersensitivity, sensation is hyper than usual. But if there is no correlation between his symptoms and incidence of attacks of refluxes, so it's a functional heartburn totally. Okay, this is summary, 24-hour. If pathologic acid reflux, it is erosive or non-erosive according to the endoscopy. If physiological, positive symptom correlation with reflux, so it's hypersensitivity. If it is negative, it's totally functional heartburn. Rapidly, we will go to importance of esophageal manometry. What is a manometry? It's a diagnostic test for any pressurization exerted by muscle contraction. So simply, esophageal contraction of the whole sphincters and esophageal body will be in this picture, colored 3D as a swallow. So this is a computer device system connected to a catheter. This catheter will record the esophageal pressurization. We will diagnose different esophageal motility disorder as achalasia, GERD, hiatus hernia, and jackhammer esophagus. This is the old, traditional, conventional manometry, just rough curves, but this is the high resolution 3D colored photos. Each color denoting certain pressurization according to this grade. Okay. The importance of manometry in cases of GERD, rapidly we have some theories can be explained by manometry. First, transient lower esophageal sphincter relaxation. It is 10 to 60 seconds spontaneous LES relaxation. So 75% of refluxes events occur during this duration. So it is a physiological phenomena, but if it is too frequent or too prolonged, will give us GERD cases. Also presence of hiatus hernia, we will diagnose with esophageal manometry. Like here, this is the LES and this is the crura of diaphragm, so there is diagnosis of hiatus hernia. And also we can do grades of hiatus hernia by esophageal manometry. Okay. Also, the LES resting pressure may be low in cases of GERD, and the more it is lower, the more is symptoms of severity of GERD. Okay, also to assess esophageal motility, either it is good esophageal motility or it is weak motility. Okay, importance of manometry in cases of GERD, these three indications. First, refractory cases. Second, before surgical or endoscopic management. Lastly, for localization of the LES. We will discuss. Okay. First, if refractory cases, what is the importance of manometry? To exclude other abnormalities which can mimic GERD and give the patient reflux symptoms. Like many patients of achalasia or hypercontractile disorders may have symptoms of GERD. If we depend upon symptoms, we can miss that these diseases can cause reflux. If the patient is arranged for intervention, surgical or endoscopic without manometry, you can miss this diagnosis. For examples, we have many patterns of achalasia. All are common in high non-relaxing lower esophageal sphincter, but according to the different parameters of esophageal body contraction, we can call type 1 as no peristalsis, no contractions at all. This pattern we call pan-esophageal pressurization in the whole esophagus from the starting till its end. It's type 2. Lastly, type 3 is a spasm in combination with high or tight LES. Also, we cannot miss jackhammer, hypercontractile, or spasm. All these disorders can mimic GERD. And we have many papers to discuss this item. The second indication before surgical endoscopic management, as we said, to rule out other motor disorders. Also, according to the esophageal motility, we can decide which angle or the procedure of the intervention. Should it be, for example, full fundoplication or incomplete fundoplication or any other according to esophageal motility. Lastly, as we said in pH impedance, we put the probe 5 centimeters above the cardia. So how we know the length of the cardia in each one? So localization of LES is by manometry. So to conclude, what is the role of pH impedance and manometry in GERD cases? First, pH impedance of therapy to diagnose refractory GERD. Also, manometry for refractory cases with normal endoscopy to rule out other motor disorders. For cases of surgical or endoscopic management and for localization of LES for pH impedance study. Thank you.